Hello, welcome back to Polymeric Biomaterials. We are in the last week of lectures, and in this week, we will be focusing our attention on the theme of biomaterial performance. And essentially, this theme is going to integrate many of the concepts we have seen so far and look at biomaterial design, polymeric biomaterials, structure property relationships, etc., from a host perspective. And in that interest, we are going to today be looking at biomaterial implantation and the host response. So as part of today's lecture, we will be looking at first some broad overview of the host response to implantation of biomaterials. And then we will look at what is famously called the foreign body reaction or FBR. We will look at an overview of that and then different aspects of it, particularly acute inflammation, which involves primarily many cell types, but primarily neutrophils and macrophages, whose responses we will look at as a representative set of examples from that set of processes that are included in acute inflammation. And then we will move on to other aspects in that timeline of events, namely chronic inflammation and the formation of foreign body giant cell and eventually fibrous encapsulation, both of which constitute the foreign body reaction to the implanted biomaterial. And as always, because the rest of this lecture, the initial part is focused on the host response, towards the end, as always, we will focus on what lessons we can learn for the design of biomaterials to minimize the foreign body reaction. So with that quick introduction, let's jump right into the lecture and first recapitulate some aspects of biomaterial host interactions that we have seen earlier. So firstly, we note that biomaterials and hosts interact in a two-way direction, and these interactions could be physical, chemical, and biological. And note the two-way arrow where the biomaterial is going to act upon the host. The host also will act upon the biomaterial. And from a performance perspective, the factors that affect performance are broadly listed here. And one can view this from two different perspectives. One is the biomaterial perspective, the other is the host perspective. So these are essentially factors affecting the performance. And from a biomaterial perspective, you can readily appreciate all these factors that are listed here because this is something we have seen in great detail throughout this course, right from bulk properties to surface characteristics to biomaterial processing, which affects the microstructure, namely pore size porosity, functionalization of biomaterials, as well as degradation and aging. Now, this also has to do with how the host is going to act upon the biomaterial. From a host perspective, factors affecting performance include the site and the duration of implantation. So, not only where you're implanting the biomaterial, but also how long the biomaterial needs to function within the host. The physiological condition of the host, namely what kinds of preconditions do they have, what medications are they on, all of these things play a role in dictating performance. Of course, temperature and solvent effects are inevitable because the body, as we have continuously said throughout this course, consists of an aqueous buffer with salts at 37 degrees Celsius. So those are going to have their own effects on biomaterials or any implanted polymeric biomaterial. And of course, there is the foreign body reaction, which is going to be the focus of this lecture. So you see that while from a biomaterial perspective, we have focused quite a bit on some of the properties that are listed in the top of this list, as well as some of the others that we have listed at the bottom. In today's lecture, the focus is going to be on the foreign body reaction, which is primarily from the perspective of the host. So rather than looking at it from the biomaterial perspective, now we are going to implant a biomaterial and ask, how does the host respond to this biomaterial? And one thing to note here is again this idea of biocompatibility, which we have seen multiple times throughout this course. But recollect that biocompatibility is a characteristic of a material host system together in a specific context and an application, right? We have repeatedly seen that there is actually no material that is universally biocompatible. So, to call something a polymer, for example, a biocompatible polymer on its own is not very meaningful, because there are multiple dimensions to biocompatibility which we have seen throughout this course, and we will see more of this in this lecture and the last lecture. But just to note that all these aspects that we have listed here go towards affecting how we understand biocompatibility. So, remember, it's a characteristic of a material host system. So, it's a system that matters rather than the material or the host itself. And when we talk about material and host system, all these factors have to be contextualized. So, now moving on to look at biocompatibility from a host perspective, right? We've looked at quite a bit of background relating to biocompatibility from a biomaterials perspective. Now we will look at it from a host perspective. And this list is not entirely new to us. We've already started looking at some of these in some detail. For example, protein adsorption, platelet adhesion, activation and release, as well as thrombosis are things we've already looked at in earlier lectures. And the other aspects that contribute to biocompatibility from a host perspective include inflammation and immune response, which will be the focus of this lecture, and of course other specialized undesirable processes which could include infection in the formation of biofilms, calcification, which is something we have looked at in some detail when we looked at blood material interactions in the previous lecture, as well as toxicity, which we will be focusing on in the next lecture. So, between these last few lectures, this lecture and the next lecture, we will aim to cover all these aspects that contribute to our understanding of biocompatibility from a host perspective. And in this lecture, this will be the key focus. Now, let's first take a look at an overview of the foreign body response or foreign body reaction to implantation. So, this foreign body reaction is called FBR. The R could also stand for response. Some textbooks will use response instead of reaction. They both mean the same thing. So, here is a snapshot of the timeline of events following biomaterial implantation. And in an earlier lecture also, I pointed out that it's good to think about this as a temporal sequence of events that occurs, so that you get a good idea of how the different pieces fit together in the broader scheme of things. So, once the biomaterial is implanted in a host, and by host we mean it could be an animal, it could be a human being. We're using that word a bit broadly, but largely we're talking about in vivo or clinical kind of host, not in vitro studies. One of the first things that will happen is protein adsorption, which can occur over the range of seconds to perhaps minutes. And all the timelines listed here are rough timelines and should be considered a bit cautiously, but they largely are true for many kinds of host responses to implanted biomaterials. The other important event that occurs is platelet activation and thrombosis, which we have seen in the previous lecture, which can last from minutes to hours. Clot formation, coagulation, all the way up to clot stabilization. All that could start over the course of a few minutes, but maybe stabilize around 3-4 hours. And thereafter, you're going to have a very distinct phase called acute inflammation, which is going to go from a few hours to several days. And then you're also going to have formation of granulation tissue, which can occur starting within a few days to several days. And then in some cases you can have chronic inflammation, which can go from days to weeks, but in some cases that can go on for many years. And foreign body reaction, which is one type of a very specific reaction to implanted biomaterials, this happens over weeks, but usually will persist for the lifetime of the implant. Now, these two have to be read together, which is that an acute phase of inflammation usually transitions to um, granulation tissue and the remodeling or repetitive processes in the normal wound healing cascade. But because we are looking at biomaterial implantation, the response is actually quite different. What you will see here is that the foreign body reaction, which is associated with what you would call foreign body giant cells, which we will look at in some detail later in this lecture, are going to persist on the surface of the implant, especially if it is a long-term non-degradable implant. These foreign body giant cells are going to persist for the lifetime of the implant, leading to low-grade inflammation and leading to, in some cases, complete fibrous encapsulation of the implant. Actually, fibrous encapsulation is going to happen in many cases. And depending on the severity of the fibrous encapsulation, one can talk about the outcomes of implantation being moderately successful or perhaps even leading to failure. And like I've just said, this foreign body reaction is seen in most cases because as we are implanting foreign objects into animals or patients, so the body is going to keep recognizing them as long as they persist. The body is going to keep recognizing them as foreign. So the goal of biomaterial design is to minimize the foreign body reaction, if not to entirely eliminate it. And now would be a good time to pause and recall two very critical aspects of this workflow, namely protein adsorption, which we saw in great detail in lecture 31, as well as blood material interactions, which we saw in lecture 32, which constitute these two aspects of the timeline of events following biomaterial implantation. What we are going to focus on in this lecture is looking at acute inflammation, granulation tissue, chronic inflammation, and the foreign body reaction. Essentially, chronic inflammation itself, the word itself indicates that it's going to last for a very long time. And foreign body reaction is one type of chronic inflammation that specifically occurs when biomaterials are implanted. And there are some very specific features associated with it. One very important feature of that is the foreign body giant cell that I talked about. The other important feature of foreign body reaction is fibrous encapsulation of the implant to isolate or wall it off from the rest of the surroundings. And that can have mixed outcomes, and we will see some examples of that later in this lecture. So, before we move further, let's take a quick look at some key aspects of this response before we start looking at details of acute inflammation and chronic inflammation. So, inflammation per se is any reaction of vascularized tissue. Essentially, if you have blood vessels in the vicinity and if there's an injury, you're going to have inflammation, right? The role of inflammation is primarily to neutralize, dilute, and barricade any injurious agents. This need not just be these agents need not just be the biomaterial itself. It could also be potential infections, any pathogens that come and invade. So all of these are usually taken care of because of the process of inflammation that starts. And broadly, one can think about inflammation as involving either an acute phase or a chronic phase. An acute response typically involves many players, but the key players are neutrophils, whose role we will look at in today's lecture, as well as monocytes, which actually end up becoming macrophages in response to an injury once they are attracted to the site. Of course, the other form of inflammation, which is not quite desirable, is a chronic response, which is going to again involve macrophages, but some specialized form of macrophages. And this foreign body giant cell and several other cell types. Now, the immune system likewise can also be thought of as innate and adaptive immunity. And what we are going to focus on in this lecture is largely responses of the innate immune system. The adaptive immune response and the complement activation are a bit more involved than what we can cover here. But the hope is if you get a good understanding of the types of responses that some of these cells can show in response to an implanted biomaterial, along with some additional reading from biology later, hopefully you can pick up other concepts related to adaptive immune responses and complement activation, which are equally important. So, that being said, the immune system largely is designed to protect against pathogens. This could be microbes, toxins, chemicals, implanted materials, foreign objects, etc. And one way the immune system, particularly the adaptive immune system, recognizes materials is by differentiating self versus non-self. So, there are markers on cells within our body that tell the immune system, look, these are my own cells, please don't attack them. And when that gets disrupted, one can end up having autoimmune diseases where the body starts to attack itself. And you can also have not self markers, markers that are not found on the human cell, which the body, the human immune cell will perceive as being not self. One example of that is the alpha gal epitope, which we will look at in the next lecture when we look at immune response to natural materials. But this is something that is not found in human cells or on human cells. And so when we look at xenograft transplants, etc., it's very important that if these markers are left behind, the body will mount a very severe immune response leading to hyperacute rejection. So we will look at an example of this in the next lecture. But what we're trying to say here is that the immune system protects the body against invading pathogens, biomaterials, toxins, and chemicals. Now, as far as biomaterial implantation is concerned, the host response typically can involve two scenarios. Firstly, we note that there are two distinct sources of injury, at least occurring in biomaterial implantation. One is the injury occurring due to the surgery itself, the incision and the trauma from surgery itself. Second is the injury occurring from the implanted foreign body. So the host is going to respond to both of them. And the two scenarios could be, one is a transplanted organ, like a xenograft, like I just said. And here there is a rejection risk by adaptive immune cells. So these are immune cells that recognize these self versus non-self markers. So if you have a xenograft that has not been processed correctly, or if you have even a tiny amount of residual cells from the donor, then that can be severely problematic. But in most cases, when you use synthetic biomaterials, this was not a problem because synthetic biomaterials are not immunogenic. So the body doesn't have mechanisms to specific mechanisms to recognize synthetic biomaterials except through protein adsorption and others. And so the host will take a slightly different approach to synthetic biomaterials and elicit an FBR instead of immune rejection. And these two are quite different. Now, before we proceed into looking at acute and chronic inflammation, a couple of important points to note about how normal wound healing happens and how biomaterial implantation is quite different. And what is the difference between them? What are the phases of healing? And why does one lead to healthy scar tissue while the other leads to FBR? So that's useful to quickly ponder over. So shown here is a timeline of events that are typically seen in normal wound healing. And this largely involves four main phases. First is hemostasis, which we have looked at in a previous lecture. Inflammation, which we're going to look at in this lecture in more detail shortly. And then you have proliferation and remodeling. Essentially, when you have normal or regular wound healing, the body, after the inflammatory phase, the body is able to mount responses that resolve the inflammation and take and processes such as proliferation or migration of cells to deposit extracellular matrix take over, eventually leading to remodeling. Essentially, this is rebuilding of healthy vascularized tissue. All these words are very important. So the tissue that forms eventually, the new tissue that forms is healthy and is vascularized. So there is enough nutrient and oxygen supply so that the body can go back to its original state, right? Shown here are some of the key processes. For those of you who are more biologically inclined in the audience, you can take a look at all of these in more detail. But broadly, you see that we are seeing a lot of the words that we have seen earlier, right? From vasoconstriction to coagulation to vasodilation, leading to other immune cells coming into the site. Then you have neutrophil responses, and then you have macrophage responses, both of which will constitute inflammation. And inflammation here typically refers to the acute phase of inflammation. And you see, after a certain point, the acute inflammation starts to go down. The inflammation starts to go down, and perhaps somewhere here, right, maybe from around end of week 1, week 2, you start to see that depending on the severity of the injury, you start to see that there is angiogenesis happening, there is matrix deposition, there is maturation and remodeling, right? And eventually, over time, the tissue is going to regain its normal strength and function. So this is the scenario with a normal wound healing response. Now, the wound healing response in a biomaterial implantation is somewhat different. Firstly, note that in the case of normal wound healing, whatever injury was there was likely not going to persist over time. Essentially, if you have cut yourself, for example, or if you have broken your arm, with time, it's not like you're going to have a permanently implanted foreign object in your body. So the body will eventually heal itself in most cases. But in the case of a biomaterial, what you have here is a permanent implant, which is foreign, which the body continues to recognize as foreign throughout the time that the implant is retained in the body. So this is going to impair the normal reparative phase. So you will still see homeostasis and inflammation, but where it starts to become different is that the acute inflammation will eventually transition not into a proliferative and a reparative phase. In many cases, it transitions to a chronic inflammation and a foreign body reaction phase. So that's sort of what we're saying here. So the implantation of the device, these two phases will begin, but then that eventually leads to the foreign body reaction and in many cases a fibrous capsule formation around the implant because of the presence of the implant in a continued manner within the body. And the foreign body reaction, as we've already said, the two hallmarks of foreign body reaction are: one is the presence of the foreign body giant cell, which are essentially macrophages that are fused together, and we will look at some mechanisms later in this lecture, as well as the fibrous capsule. So these two are classical hallmarks of the foreign body reaction to implanted biomaterials. Now note that this is quite different from the type of remodeling and the healthy scar that usually happens with the normal wound healing process. And obviously, the severity of the foreign body reaction is going to be dictated by biomaterial properties. And this could include properties right from shape, size, surface charge or hydrophobicity, stiffness, porosity, and pore size, as well as any leachables that come out from the material over time. So all of these factors will play a role in dictating how strong of a host response and how long of a foreign body response the body sees. Now, potentially, we're listing out two extreme responses here. One could be considered a success, the other could be considered a failure of a biomedical device. Now, in a beneficial response, what you see is a thin and organized fibrous capsule with a very few foreign body giant cells and stable vasculature around the implant, the formation of blood vessels around the implant. Now, what is not considered good includes a thick and dense fibrous capsule, many foreign body giant cells surrounding the implant, and abnormal vasculature. So these two represent sort of the extremes. Now note that not seeing the foreign body reaction is very rare, because these are foreign objects that are implanted. They're almost always going to get a foreign body reaction. Although later on in this lecture, towards the end, we will look at strategies to minimize or even perhaps eliminate it. But what you want to note here is that even with the foreign body reaction, this kind of a reaction can be extremely detrimental, where you have a thick dense capsule with numerous foreign body giant cells on the surface of the implant, continually trying to get rid of the implant through degradation mechanisms, as well as the formation of abnormal vasculature or complete cut off of the supply of the blood vessel network once it is fully encapsulated. Whereas the positive or the more successful outcomes are shown in the beneficial outcomes. And what we note here is, from a biomaterial perspective, broadly speaking, these are not set in stone. These are what you would call rules of thumb. This is just based on years and years and years of experience with the clinic that we have gathered this kind of information. Typically, resorbable polymers, perhaps used in the context of a tissue engineering application, rough and hydrophilic surfaces, implants that are porous that can promote cell infiltration, and biopolymers typically tend to integrate well. It's the synthetic non-degradable implants, perhaps with smooth surfaces, with micromotion, essentially implants that move around quite a bit, causing irritation, or non-porous materials, an example of which we will look at the end of this lecture, tend to get engulfed in a fibrous capsule. And now would be a good time to pause and reflect and recall that these are all aspects that we have seen throughout this course, right from surface properties to microstructure, porosity, pore size, biomaterial processing, and how all of these are connected to scaffold formation. So all of these things we have seen in quite some detail from a biomaterial perspective. Now we are just connecting that to the performance of the biomaterial in a host. Now, before we move further, we will note that a desirable tissue response to implanted biomaterials involves functional vasculature, right? That's what you would ideally want. But with many inert materials, typically, a fibrous capsule is an acceptable result of the healing wound, of the wound caused by implantation. So this fibrous capsule per se is not bad. So it's not good to treat it like a villain. It's not per se bad. Like you already see here, there are at least two different ways to think about a fibrous capsule formation, where one of them is clearly a beneficial outcome. So the fibrous capsule formation is something that is taken for granted with the implantation of these kinds of biomaterials. And of course, some strategies to sort of minimize that are shown here in green as well. But it's the severity that really matters, right? That's where we talk about outcomes that are beneficial or outcomes that are detrimental. Now that stage being set, we will now start looking at one of the key aspects of this host response, namely acute inflammation. So we've had a biomaterial implanted, protein adsorption has happened, then thrombosis has also occurred and that is also stabilized, coagulation, all of that has happened. Now we're in the acute inflammatory stage of the that timeline that we saw earlier. So firstly, we note that this is the immediate response to injury. In this case, when we say injury, we're talking about injury occurring both from surgery as well as the implantation of the foreign body. This can last from hours to days. And the four classical hallmarks of inflammation, and this is true even if you hit yourself and you have swelling, doesn't have to be a very major injury. You will see redness, swelling, localized increase in temperature, and pain. These are considered the four hallmarks of acute inflammation. Another important biological hallmark is localized neutrophil accumulation. Neutrophils are very important immune cells. These are sometimes called the first responders to any injury. And what we will focus on in this part of this lecture is to focus on looking at the responses of both neutrophils and macrophages, which are the dominant players in inflammation. So neutrophils and monocytes, which eventually become macrophages, infiltrate, and you also have immune cell chemotaxis because a bunch of signaling molecules are released at the site of injury, signaling these immune cells to migrate to the site of the implant or the injury. And these neutrophils and macrophages that are there at the site interact with these surfaces through surface adsorbed proteins, leading to secretion of signaling molecules such as cytokines, release of reactive oxygen species, and proteolytic enzymes for degradation and phagocytosis. So, these are all some things we will look at in just a bit. But what we want to highlight here is that the primary response, the primary job of the neutrophils and macrophages that are infiltrating the injury site or the implant site is to get rid of the implant and any potential infection and to resolve it as quickly as possible. And in most cases, that resolution is not going to happen, as we will see later, because biomaterials that are typically implanted are quite large for these cells to engulf, which is essentially what phagocytosis is. So, that leads to chronic inflammation. And typically, inflammatory effects include vasodilation of local blood vessels. So, remember, the first response is vasoconstriction during the platelet plug formation and coagulation. Thereafter, vasodilation happens for some of these immune cells to phagocytic immune cells to migrate to the site of injury. And that is done in response to chemotactic factors. And their goal, like we've just said, is to clear the site of debris and pathogens. In this case, when you have biomaterials that are implanted, it's not just debris and pathogens, it's the biomaterial itself. It's the implant itself that these fellows want to get rid of. And to connect this back to blood material interactions, so the fibrin degradation fragments and pathogen-derived fragments, if you have infection, are typically considered chemoattractants for neutrophils and macrophages. So, these are all cells found in the blood. The way they know to come and invade the site of the injury or the implant site is through these signaling molecules that are secreted from the implant site. And in terms of the timelines and the acute inflammation itself, what we note here is typically within an hour or so, you have neutrophil infiltration and monocyte infiltration happens within a few hours thereafter. And once the monocytes have infiltrated, they typically differentiate into macrophages, and macrophage responses dominate over a week to 2 weeks, right? Depending on the nature of injury, depending on the severity of injury. And as we have already seen, in a normal wound healing cascade, this should be followed by proliferation of fibroblasts, deposition of extracellular matrix components, and reparative processes that lead to rebuilding of tissue. But in the case of many biomaterials, typically after this phase, you will see chronic inflammation that lasts months to years, simply because the biomaterial is going to remain there forever. Now, some quick caveats to note. The first thing we note here is acute inflammation is actually not a bad thing. A short-lived inflammatory stage is very, very critical to encourage the subsequent reparative phase of wound healing. And that's critical because if you don't have the initial inflammatory phase, then you're not going to have other processes that follow thereafter for repair and wound healing. So, the inflammatory stage is quite critical. Where it becomes a problem is when it is not short-lived. That's when it becomes chronic. So, this transition from a pro-inflammatory to a pro-healing, this is really critical, and macrophages are a very, very important player in this transition. So, from a pro-inflammatory landscape, if you will, to a pro-healing or a pro-repair landscape is critical. And an extended inflammatory phase is typically damaging. Again, depending on the severity, the goal is for biomaterial design to keep it to a minimum. So, we've already hinted at the role of neutrophils. So, let's look at their contributions to acute inflammation in more detail. Essentially, neutrophils in the blood undergo a process called extravasation from the vessels to the site and adhere. So, under normal conditions, these neutrophils circulate in the native state within the bloodstream. But once there is an injury or there is an implantation, there are 4 key steps that these neutrophils will undertake to migrate to the site of tissue. They include rolling, activation, adhesion, and migration. Again, remember that this is not unlike platelet activation that we saw earlier, although that's a very different type of a cell. In fact, those are non-nucleated. What is common between all of these is that there are cues that promote migration and activation, without which these will function normally. This ensures that the body does not keep activating them under circumstances that don't require them to be activated. So, shown here is again a detailed cartoon of the mechanisms of neutrophil activation and migration. Without getting lost on the details, what we will note here is the rolling stage typically involves weak adhesion of the neutrophils to the endothelial layer or the vascular endothelium. So, they will weakly adhere through these molecules called selectins. So, P-selectin and L-selectin are shown here. So, these are factors through which the neutrophil can weakly bind to the vascular endothelium, and it's called rolling because because the binding is weak, they still can flow. So, it almost seems like the neutrophil is rolling on the surface of the endothelium, following which they get activated and can adhere through integrin mediated signaling, and that can happen here. So, this is adhesion, and their adhesion itself causes them to get activated, after which what will happen is they start to change their shape and crawl. So, a good analogy to think about is Navy SEALs, for example, who go and infiltrate enemy bastions. This is not unlike what they will do, right? So, what they will do is they will crouch, they will crawl, and they will slowly infiltrate. And that's literally what these guys are doing, because the goal is to eliminate the enemy, and in this case, the enemy is the foreign object. It could be bacteria, it could be pathogenic bacteria, it could be debris, it could be chemicals, it could be the biomaterial. All of these are considered enemies as far as the neutrophil is concerned. So, these fellows will start to change their shape and then crawl and then migrate through the spaces between the endothelial layer that is opened up because of the injury. And once they go through, they can do a few different things. One is phagocytosis. Now, neutrophils contain granules with enzymes that join with phagocytosomes to digest any foreign matter. So, these are cells that can secrete enzymes, proteolytic enzymes that can digest, literally digest foreign matter. But typically, the surface area of most biomaterials that are implanted is much greater than the cell. So, there are limitations to how big of a debris these cells can sort of dissolve or digest. So, when biomaterials that are much larger than their own size are implanted, only partial degradation is possible in a process called frustrated phagocytosis, which is another very important aspect that macrophages will also show. So, we will see some of these details when we look at macrophages responses, because this is better understood for macrophages. So, essentially phagocytosis is engulfing of foreign matter, and you're literally these neutrophils are taking in this foreign matter, digesting them and spitting them out. Right? That's sort of broadly, in a very crude sense, what phagocytosis is. They also can perform the function of respiratory burst, essentially the production of reactive oxygen species to eliminate foreign agents and compounds promoting oxidative degradation. So, oxidative degradation is severely problematic in the body, and neutrophils typically secrete reactive oxygen species to sort of neutralize that kind of an assault. But remember that ROS in itself is problematic, and so it can cause unintended tissue damage. But the role of neutrophils is sort of limited. There's only so many things they can do. But one of the key things that they do is call for backup. So when they realize that they are not able to combat the enemy on their own, that's when they call for backup, and this is through immune cell recruitment. So they start producing cytokines and signaling molecules and chemokines for the recruitment of monocytes, which eventually become macrophages once they come to the site of the injury. So that's very briefly what neutrophils can do. In fact, to continue that analogy further, one interesting thing that neutrophils can do is also something called netosis. These are essentially neutrophil extracellular traps. These would be considered, if you want to use that analogy, suicide bombing. Essentially, the neutrophils sacrifice themselves trying to get rid of the foreign matter. So, something that you can maybe look up to see what that means in this context. Now, moving on to the macrophage response. Now, the neutrophils have realized that perhaps they need more reinforcement. So, they've called the macrophage, the monocytes in through signaling molecules. So, these monocytes that are in blood have been now recruited through chemotactic cues secreted by the neutrophils. And these monocytes now extravasate to the site of injury and differentiate to macrophages. Of course, you also have tissue-specific macrophages that also act. And macrophages do many functions, but broadly, two functions that we will look at here are, one is phagocytosis, which is again something that we just saw with neutrophils. This is literally engulfing of foreign material and then digesting them and then throwing out the waste, right? So, this is going to take care of any foreign debris, pathogen, etc. that these cells can engulf. Now, typically, if it's a degradable material and if the size is small enough, right? So, of the order of say 10, 20 microns, right? So, tens of microns, about the same order of magnitude size as a cell, then typically these cells can digest them. It's a size dependent effect essentially, phagocytosis. Typically these cells can digest them and get rid of them, but when they realize that the material is much bigger than their own size, they start to fuse together to form these foreign body giant cells. So, sometimes they can degrade and form scar which can be remodeled, especially if the material is degradable. But in many cases, the material is not degradable. So, non-degradable particles will end up accumulating, while large biomaterials lead to frustrated phagocytosis, where the foreign body giant cells sort of become frustrated because they are unable to, even after fusing and becoming bigger, they are unable to degrade the biomaterial. Phagocytosis has an interesting history. The scientist here is a Russian scientist named Meshnikov. He won the Nobel eventually in I think 1908 for his contributions to understanding of immune responses, particularly innate immune responses, and he was one of the first people to describe phagocytosis. He was a man who wore many hats. He also spent quite a bit of time trying to understand aging in the body. He also spent a lot of time trying to understand the role of the gut bacteria towards promoting specific types of immune responses. In fact, famously, when there was a cholera epidemic in France, he was trying to find out reasons to combat that and develop vaccines, etc. And he actually, to test some of these things, he drank liquid that contained cholera, and because he wasn't affected, he took a greater risk and gave it to some other volunteer who also wasn't incidentally affected. But only when the second volunteer, another volunteer whom he gave it to, nearly died, that's when he realized that perhaps there is something in him and the first volunteer that didn't cause the cholera to become explosive, while it caused the second or the third volunteer to nearly die. And that led him to postulate that gut bacteria could be playing a very important role, eventually leading to the use of probiotics, which is now a multi-million-dollar industry. What's interesting about this is this man's passion for science. He was willing to, of course, I'm not at all suggesting that this is ethical, But the passion was for science was so intense that he didn't mind drinking infected water infected with cholera to test on himself and perhaps on a poor unsuspecting couple of volunteers. So what the take home message is not the fact that he drank that liquid. The passion for science is what comes through in some of these lessons that we can learn from these scientists. Um, anyway, coming back to um, macrophage responses and acute inflammation. So the other thing that they can do apart from engulfing, which is essentially phagocytosis. So this is engulfing. The other thing they can do is they also serve as antigen presenting cells. So activated macrophages show increased expression of MHC2, which allows the um, presentation of the antigen to lymphocytes, which constitute the adaptive immune response. And interactions between the lymphocytes and the activated antigen presenting macrophages, like I said, triggers the adaptive immune response, which is a fairly involved and a complex set of processes, which you will not be looking at. But if you are interested and you are more biologically inclined, I would suggest looking at the role of adaptive immunity and complement activation in biomaterial implantation. Because our focus is more polymeric biomaterials, we are not spending any time on this aspect. That doesn't mean they're not important, they're extremely important. But in the interest of time, what we're trying to do is focus on one type of response, primarily the acute response, so that you get a good sense of the mechanisms involved, and perhaps it will be easier for you to appreciate adaptive immunity and complement activation in the context of biomaterial implantation if you do some outside reading later. And once the um, acute inflammation has set in, at some point it has to resolve for the next set of processes to work. And typically, in what you would think of as a normalized wound healing process, is macrophages will produce cytokines that increase the expression of adhesion molecules in endothelium. And as we've already said, secreted cytokines will attract and recruit the adaptive immune cells, and more importantly, fibroblasts. So these are cells that will start secreting new matrix, new extracellular matrix, collagen, and so on. These macrophages will also release the vascular endothelial growth factor to attract endothelial cells, which promotes new blood vessel formation. So if you recollect one of the definitions of biometric implantation success that we saw earlier, one of the characteristics was that this would be resulting in functional vasculature, right? And so this is what happens there, where fibroblasts come in to start secreting newer extracellular matrix, while macrophages secrete VEGF to attract endothelial cells that can now start laying out new blood vessels. Of course, this is the case with the regular normal wound healing response. We'll also find something called a granulation tissue. Now, this is different from granuloma, not the same. So, please don't confuse yourself with these two terms. Granuloma is not the same as granulation tissue. I would suggest you look up what granuloma is and try to understand the difference between granuloma and granulation tissue. Essentially, granulation tissue is one of the indicators that angiogenesis is happening and the reparative processes have begun. So, this is essentially characterized by pink, soft and granular tissue due to the presence of blood vessels that promote angiogenesis. And typically, factors from neutrophils and macrophages will start promoting migration of fibroblasts and endothelial cells within 3 to 5 days, right? And these fibroblasts will start to produce extracellular matrix, essentially collagen and proteoglycans, and granulation tissue will start to form around the implant within 5 to 7 days. And this is typically a good indicator of inflammation-induced healing. So this appears as pink, soft and granular tissue, and this is typically what surgeons will want to look for once healing has begun. Now, granulation tissue in normal wound healing will eventually lead to a healthy scar formation. So you can divide this into two. In a regular reparative or a wound healing process, granulation eventually serves as a precursor for remodeling, right? Reparative or remodeling processes. But in the case of biomaterial implantation, as we have seen throughout, this granulation tissue fails to go down this road, but then now starts to become a hotbed in some sense for chronic inflammation, where the macrophage activity starts to change quite dramatically, leading to the presence of foreign body giant cells. So that's what we're going to look at next. And shown here is a cartoon or a schematic of what would happen with macrophages in the regular wound healing processes. This is typically again not seen with biomaterials. So until the initiation phase, so this is what you would call the acute inflammatory phase, where macrophages start to become pro-inflammatory. And nomenclature wise, these are typically designated M1 macrophages, although these designations are a bit problematic because in biology, it's now quite well documented that macrophages responses constitute a spectrum. And it's very difficult to distinguish exactly an M1 versus an M2 response, and even M2, which is sort of a reparative or a wound healing response, can have multiple subtypes. Anyway, those distinctions set aside, we are seeing that in the first phase of tissue injury or infection, these macrophages become M1 like pro-inflammatory macrophages that secrete pro-inflammatory factors, namely TNF alpha, IL-1, INOS, which is a very important inflammatory factor. So this leads to pro-inflammation, antibacterial effects, matrix degradation, and tissue deconstruction. Essentially, this phase is what combats the enemy, whether it's a bacterium or it's a chemical or it's debris or an implanted biomaterial. But in the other cases, typically, if it's a normal wound healing process, these macrophages make a switch to an M2 kind of a macrophage, which can involve both wound healing or reparative macrophages essentially. So you see that the macrophage phenotype has switched from M1 to M2, and that is characterized by the secretion of different types of cytokines that are associated with a healing response, particularly IL-10 and TGF-beta, right? Of course, VEGF as well, which will eventually lead to new blood vessel formation. So that typically results in anti-inflammatory processes, angiogenesis, matrix synthesis, and tissue remodeling. So the initiation phase, which is just the acute inflammation, is typically followed by the resolution phase, right? Now, with this picture in mind, you can now contrast this with chronic inflammation that occurs with biomaterials, particularly long-term implants. So the persistence of the inflammatory stimulus, because the biomaterial continues to stay in the body, especially if it is non-degradable synthetic materials, and especially if it can move around, then the cells that are involved, namely monocytes, macrophages, lymphocytes, are not going to stop doing what they're doing, but continue it, but more vigorously, right? So these cells are responsible for driving subsequent repair mechanisms, and typically it's a combination of host tissue regeneration versus scarring. But in the case of biomaterial, this can last several years, perhaps the lifetime of the implant, because of the persistent stimulus. So just again to contrast this, in a normal wound healing kind of a scenario, this granulation tissue is transient and is reparative, and it resolves as the tissue remodels and new matrix starts to get deposited with stable blood vessel network. But in a biomaterial implant, the granulation tissue typically fails to resolve and the response evolves into a foreign body reaction. And that's sort of what constitutes the chronic inflammatory phase associated with implanted biomaterials. Again, FBR is seen almost always. It's FBR per se is not the problem. It is the severity of the FBR that sort of determines the outcome of the implantation. And persistent activity of foreign body giant cells on the surface of materials can actually lead to biomaterial destruction. One example of that is stress cracking, and this is typically seen as environmental stress cracking of polyurethanes, which are used in, and as we have seen earlier, if you can recall, as insulation for Can you recall where we have seen this? So if you're able to recollect, you will be able to immediately realize that this is typically used as insulation for pacemaker leads. And polyurethane is particularly problematic because of the linkages. So it can undergo oxidative degradation, especially in the presence of foreign body giant cells, leading to environmental stress cracking. And once the cracks and pits form, they will cause more and more pits, eventually exposing the wire itself, which can be severely problematic because it can lead to short circuiting and so on. So these are some things that are important to keep in mind when designing biomaterials. So we'll take a more closer look at aspects of this chronic inflammation and the foreign body giant cell formation. Essentially, these foreign body giant cells are found on the surface of most biomaterials. Because these macrophages have realized now that they cannot phagocytose, they start to fuse together 10 or so macrophages to form these foreign body giant cells to try and see if the bigger fellow can now engulf the surface. That is typically also not easy to do. So they will undergo in a sort of a vicious cycle this frustrated phagocytosis, which involves continuous release of degradation and enzymes around the implant, while the foreign body giant cells continue to remain on the surface of the implant for life. And shown here is an image from silicone leakage from an implant or cutaneous injection for aesthetic or cosmetic purposes, leading to inflammatory reaction with foreign body giant cells. So the white big round circles that you see are likely the silicone, and you see that there's a lot of multinucleated foreign body giant cell kind of activity around these, and that is typically problematic. Now, silicone is something that we have seen in some detail, particularly structure property relations, when we looked at synthetic biomaterial polymers as part of lecture 17. So now would be a good time to recall some of those things and connect it to host response. So there we would have seen structure property function relationships. We are seeing the performance of those and the potential issues that can occur with those in this lecture from a host perspective. And finally, if the body realizes that the immune system realizes that it cannot degrade the material through phagocytosis, it's going to result in fibrous encapsulation. So this typically involves excess proliferation of fibroblasts as opposed to routine proliferation of fibroblasts and matrix deposition that is stable in the normal wound healing response. In this case, this leads to excessive proliferation of fibroblasts, leading to a lot of collagen deposition and thick collagen deposition and fibrous encapsulation. Essentially, the fibroblasts and collagen surround the material, cutting off blood supply, etc., and isolating or walling off the implant. So this leads to isolation. Now, it's when it leads to fibrosis where it is a problem, where if you have dense aligned collagen scar produced by fibroblasts, that is when the implantation becomes problematic because now the capsule is so thick that the material is unable to interact with the outside environment and is not able to do its function properly. But in the good case scenario, even if the FBR lasts for the lifetime of the implant, it's typically low grade chronic inflammation where remodeling is slow, and sometimes continued inflammation, depending on the severity, can lead to calcification, which we have seen earlier, or perhaps even failure of the implant. And we say failure here, even the implant not being able to do its function. For example, if you're putting glucose sensors and you can't monitor them because of walling off, that is considered a failure. And as we've repeatedly said, FBR by itself is not problematic. It's the capsule thickness, which is the severity of one indicator of the severity of the FBR. So if you have thin and smooth granular tissue with stable vasculature, right, perhaps a few cells thick, right, then that's typically considered good healing. Whereas if you have a thick capsule with a lot of foreign body giant cell activity, maybe tens or hundreds of micron thick, then that's going to wall off and isolate the capsule. And that's not a good thing because it's going to interfere with mass transfer and nutrient barrier because the blood supply is cut off. And for example, in a glucose sensor, if the blood doesn't even reach it, it's not going to be able to sense anything in the blood, right? So this can be a very, very problematic scenario in the long run, right? Now, to sort of wrap all of this together, from a biomaterial design perspective, we note that biomaterial design seeks, as an example, either long-term monitoring, for example, in the case of glucose, it's a diagnostic sensor, or you can have drug release and cell incorporation if it's a therapeutic. So one is a diagnostic example, the other is a therapeutic example. So this could be something like a tissue engineering strategy. But if you have very severe and prolonged FBR, and that's very, very important, these qualifiers are extremely important. Just saying FBR is not very meaningful because you will almost always have FBR. It's the severity and the duration of the FBR or the host response that actually matters. You can typically have a very thick, if you have a very thick fibrous capsule, then you're going to have loss of glucose monitoring, for example, in the diagnostic case, or reduced rates of drug release. If you have drug-eluting stents, you're going to have very, very slow, poor diffusion of the drug because you've now walled off the implant in a capsule. Or you can even have alteration of the microenvironment because of wear and degradation, right? And one very typical example that's often cited in the literature is that of these silicone implants used for breast reconstruction, especially if somebody has undergone mastectomy and they want to undergo this kind of a reconstruction. Typically, these shown here is a photo of scar tissue capsule formed around the implant and removed during what's called capsular contracture surgery. Capsular contracture is a very, very painful, serious complication of these kinds of implants in the long run, where these myofibroblasts, the fibroblasts that have surrounded the implant, generate contractile forces as they deposit collagen and shrink and compress, making it very painful for the patient. Now, there are multiple reasons why this occurs with these kinds of implants. One postulated reason is potentially small amounts of gel leakage, silicone leaching out in small amounts from the implant. As we saw on the previous slide, right? If you have small silicone amounts releasing, you can have a lot of foreign body giant cell activity around those. Motion, right? Movement of the implant, that itself causes a lot of irritation. And the third and most importantly, from a surface design perspective, these are smooth surfaces. And as we have already noted in an earlier slide, these smooth surfaces typically tend towards capsule formation because the cells don't have any way to infiltrate and sort of create new tissue. So smooth surfaces are typically, or rough edge or sharp edges typically are problematic when it comes to biomaterial design. And in that interest, we can now wrap up by looking at some strategies for biomaterial design to reduce the FBR. And these are not completely new. We have already looked at some of them in earlier lectures. We're just looking at it in a newer context. Because everything begins from the surface, primarily surface properties play a very important role. One way to sort of reduce the FBR is albumin passivation, which is, again, this is all typically done with synthetic materials, right? Because the body naturally recognizes natural materials, natural polymers. We're primarily talking about synthetic materials here. You can have protein adsorption reduction because albumin has already taken up many of the active sites, if you will, on the surface. You can also have PEG coatings, as we have seen, or brushes, which reduce the neutrophil adhesion. Surface charge plays a very important role. We've already seen that proteins will adsorb much lesser on zwitterionic surfaces. Again, these are all concepts we have seen in lecture number 31 when we looked at protein adsorption in quite some detail. You can also have hydrogel coatings because of the hydration layer. They will prevent protein adsorption, which means you're going to have less macrophage binding because remember, these cells interact with materials through adsorbed proteins. And of course, you can also have a combination where you can coat it with ECM proteins, and that can potentially elicit a more favorable response. These are all some generic strategies. Of course, there are lots of there's a lot of work out there on how to reduce FBR for implanted biomaterials and with very, very specific, very specialized strategies and specific applications. And these are some broad ways to think about biomaterial design to reduce the FBR. Of course, you can also have to control the anti-inflammatory and pro-inflammatory responses. You can also have release of anti-inflammatory cytokines and steroids. For example, dexamethasone is a potent corticosteroid that is used in steroid-eluting stents and pacemaker leads to reduce the implant-related inflammation. So, this will slowly release dexamethasone locally. It's not good to give this systemically, so it can release it slowly locally to reduce the inflammatory response associated with the macrophages around the implant. And remember that we have already seen the role of electrospun scaffolds. We looked at lecture 18 and their role in releasing dexamethasone. We looked at mechanisms again there from a structure property relationship perspective. Here we are contextualizing it for application and performance. So with that, we will end this lecture, and in the next, which is the last lecture, we will be looking at taking this forward to see how can we translate biomaterial devices and look at again aspects of biocompatibility as well as some regulatory aspects that dictate biomaterial device translation.